All right. Hello, everybody. First of all, let's welcome our Dr. Zhao. I'll do a brief introduction about Dr. Susan Zhao. Okay, we've known each other really well. We were schoolmates, classmates in high school. From the start, Dr. Zhao has been following her passion on biology, medical domain, show a strong interest, drive, and talents in this area. After Dr. Zhao coming to US, following her passion for research, she went on to graduate at magna cum laude with an MD degree from Harvard Medical School in 2005. Since then, Dr. Zhao completed her internal medicine internship and residency from Massachusetts General Hospital in 2008 and cardiology fellowship from University of California, San Francisco in 2011. So the purpose of this meeting is that I want to offer a good opportunity for our Carnegie Mellon students because our students are conducting the user researches, especially in the medical domain, specifically cardiovascular, this domain, where Dr. Zhao have the expertise in this area. Okay, so with that, we are going to give a round of applause to Dr. Zhao. Thank you so much for spending your time tonight with us, our students. And also, I very much appreciate our student team 1, 3, 4, 5. You spend the time, really think deeply to come up with the interview questions. Appreciate that, all right? So due to the time constraint, we are going to allow each team to raise one question and then take round robin to start the second question in multiple rounds. Okay. Dr. Zhao, would you like to give some words before our interview?
Oh, Catherine, thank you so much for a warm welcome. It's a great pleasure to be with the group. And I've been a practicing cardiologist for the past 11 years and in the Bay Area. So with the benefit of seeing a wide variety of pathology and also from diseases around the world. So I hope that I can share some of my insights with the group. I think I don't quite get an idea of what the audience is. I mean, is it a graduate school? Are they
Sure.
Yeah.
I can give a brief introduction. Sorry about that. So this group of students, they are the graduate school students working on the software management. In my class, software engineering management class, the full fall semester.
Okay,
so they are going to start their project work, prototyping from the ideation phase. So in this semester, we select the domain, healthcare related topic. So they can select the heart disease, COVID, autism, variety of different domains.
Okay.
So specifically on this call, these are the 4 team of students. They are very passionate about the cardiovascular domain. And I want to learn the domain knowledge and address some of the questions in their mind.
Okay, great. I'll see what I can do. Okay, go ahead. Fire away.
Thank you so much. So let's get started. Team 1, your first question, please.
Hi, Doctor. I'm Apurva. I'll be asking you the first question from Team 1. So we'd like to understand better how different types of cancers, basically like breast cancer, cervical cancer, skin cancer, lung cancer, etc. How does that affect a person's heart health?
Oh, that's a great question. There is actually a separate field called cardio-oncology. Or oncocardiology, depends on, if you ask the cardiologist versus the oncologist. The oncologist is a specialist taking care of patients with different kinds of cancers. Yeah, so there's a spin-off from mainstream, from a general cardiology called a cardio-oncology. So the effect of cancers on the heart, cardiovascular system is multifaceted, right? So directly, there are some cancer that can directly invade the heart, metastasize to the heart, but that's actually a very small fraction. Most of the issues involving cardio-oncology are actually related to the cancer therapy, the pharmacological therapy, and also radiation therapy, if the radiation involves the chest. So the bulk of cardio-oncology is indeed related to the medications targeting the cancers. And in the past, there's the chemotoxic agents, particularly adriamycin, doxorubicin, that can cause a dilated cardiomyopathy, essentially the heart failing out. The most recent years with the emergence of a wide variety of immune checkpoint inhibitors, the MAPs, if you check, it's called immune checkpoint inhibitors. They are really notorious for causing a wide range of cardiovascular pathology and problems, morbidity and mortality. For example, myocarditis, pulmonary hypertension, heart failure, pericardial effusion, so you name it. Most of the field of cardio-oncology is indeed related to the therapies targeting cancers.
So is there any cancer, any specific type of cancer which basically is more prevalent, or like suppose lung cancer is more predominant, a person who's having a history of lung cancer versus a person who's having a history of skin cancer per se is more susceptible to a heart disease or anything of that sort?
Are you still talking, you're not talking about therapy, you're talking about the
Yeah.
cancers directly involving the heart, right? Yeah. So with that question, they are primary cardiac tumors, which means those tumors, either malignant or benign, they grow directly in the heart. And so that's one category, is primary cardiac tumors. There's a second cardiac category, which is metastases, right? The primary tumor is somewhere else, but it sent, distant metastases to the heart. Right, for primary cardiac tumors, if for the benign ones, you have, you have sarcoma, you have, fibroma, you have myxoma. Those are usually benign tumors. They cause problem because they're space occupying and interfere with normal function. So, for example, they grow on top of the valve and obstruct the valve outflow. Or they cause inflow obstruction. So they're mostly space limited problem, but there are malignant tumors, usually the sarcoma type, and angiosarcoma or primary sarcoma. They can cause bleeding, clot formation. They can even erode the tissue and cause essentially the heart to burst. So that's the primary cardiac tumor. They're exceedingly rare. For the metastases, breast cancer, lung cancer, melanoma, they're known to send metastases to the heart. And usually that's, once you have metastases to the heart, and they cause effusion, like a blood collection around the heart, they erode, they encase the major arteries. So that's a very terminal diagnosis once the metastases have gone so far as into the heart.
Definitely, you have great domain knowledge. Glad we recorded. We need to digest all this information. Thank you so much.
Thank you.
Let's move on to team 3. Team 3, your first question, please.
Yeah. Hey, Dr. Zhao, how are you doing?
Good, thank you.
Yeah,
How are you?
this is Tejas. I'm doing great. This is Tejasvi. We are doing a study on COVID, and I just want to ask you my first question. Can you tell me about how heart rate is affected by COVID? Like we want to know both during and after the phases. So if you can please talk about that.
You're talking about the cardiovascular effects of COVID?
Yes. Yes.
Right. So, obviously that is still a growing, field, and a lot of ongoing research. It's been targeting COVID and cardiovascular health. And I think I did send Catherine some references. One is COVID effect on the cardiovascular death from a population health standpoint. The other one is specific cardiac diseases that can emerge as essentially a co-occurrence with COVID infection. So, in general, there's still 2 different kinds. One is the de novo cardiac diseases come out as a result of COVID infection, right? So you're essentially healthy. You get the COVID infection and boom, something happened to your heart. right? And there are also people with pre-existing cardiac conditions, heart failure, heart attack in the past, cardiac arrhythmias, and once they got COVID, those conditions can get exacerbated, get worse, right? Because of COVID. So in the hospital, we're certainly seeing a lot of particularly elderly patients once they get COVID. Well, not so much COVID alone, like if they get a really severe case of flu, they also come in with heart failure. They come in with, you know, what they call demand ischemia. They come in with arrhythmias. And all their baseline cardiac comorbidities is getting worse from all the insult from a COVID infection. Okay, that's not specific to COVID, but that may be more serious with a serious COVID infection, right? For those who are, you know, baseline, they're fine, they have no cardiac conditions. The most commonly quoted disease from COVID is actually myocarditis, which means inflammation of the heart muscles. All right, so I think the reference I sent to Catherine specifically talk about young males from 15 to 24 years of age. That's probably the age group with the highest prevalence of COVID-associated myocarditis, okay? But still exceedingly rare. If you look at the literature, anywhere from like 20, 30 to 400 cases per million 15 to 24 years age male. Okay, so that's still exceedingly rare. But that's, you know, of all the COVID-associated myocarditis, it's probably the most talked about disease condition. Okay.
Okay. Can I
yeah.
ask a small follow-up to that, please?
Yeah.
Specifically on heart rate, is there anything observed practically?
With COVID, after
yes.
you know, after a person has contracted COVID, what is the heart rate response to it?
Yes.
In general, you know, if in normal heart rate, so with any infection, right, any challenge to your physiological status quo, the heart responds to speeding up, right? So we call tachycardia, which means the heart rate will be faster. Okay, like if you run a marathon, you're dehydrated. If you hike up the mountain, your heart will go fast. If you're agitated, if you're like scared, if you just had a car accident, your heart will be fast. So same thing, you know, if you lose some blood, your heart will go fast. So in a reaction to infection, the normal reaction the body has is to rev up the heart rate. So that's if you have normal heart rate. But if you have a baseline arrhythmia, like there are different kind of arrhythmias, particularly elderly folks, they have something kind of atrial fibrillation, they have premature irregular heartbeats, that will be worsened by COVID.
Okay, got it. Thank you so much.
Thank you. By the way, let me share my screen. Dr. Zhao sent us some readings, relevant readings ahead of the time. I already forward to our email via Canvas. Feel free to take a look. These are the information. Okay, let me stop sharing. Let's move on. Move on to team 4.
Hello, doctor. In our project, we are trying to use data from wearables to predict heart risks. So our question is like, we are all going for annual health checkup or periodic health checkups, and then doctors will take our blood pressure or ECG when we are there. But since or during this age, the penetration of wearable devices are more, and there are many FDA approved devices, even though why there is a friction to accept the data from the wearable devices for the analysis of one patient's ECG or blood pressure. So doctors will get a superset of data if they ask a patient to bring some of your readings from your iWatch or something like that. Is there any reason for that?
Yeah, so that's a very good point. You know, I think there's a few things I have to say. Number one, medical field, even we're situated in the heart of Silicon Valley, we're always 10 to 20 years behind the forefront of technological advances. So it takes a long time for technology to permeate into medical field. There are many reasons why we're behind. And one of the reasons being the doctor is not really very tech minded. The other one is the regulations and essentially supervision, and you have all the bureaucratic red tape to go through to introduce any new technology. So that's one. We're inherently just slow in adapting. Number two is, I think in terms of the wearables, the consumer products, home self-generated monitoring data is a big chunk of data, and the quality of the data is debatable. Okay, so the Apple Watch, I know Apple Watch has some algorithm to tell you when your heart is going into arrhythmia, but I see a lot of false alarms. Okay, so that's number two. The quality of the self-monitoring data, the QA is not there. The number 3 point is, we don't have the manpower.
Okay.
We simply do not have the manpower. Every day I spend hours and hours clearing up my electronic in-basket from my colleague, from the hospital, from patients. We don't have the manpower to take 30, 40 messages from patient asking, hey, this is my Apple Watch is showing me, do you have time to adjudicate? Is it real? We don't have the infrastructure and the manpower and labor force are not ready to take on this tsunami of information. So I don't know it's probably up and coming, but I don't think the workforce is prepared to handle it.
Okay, got it. Yeah.
Very good. I just want to add on to it. One example, like
Sure.
an ECG reading, right? Like Dr. Zhao just mentioned, the medical degree of ECG, they have a 12 lead, performed in the hospital. Whereas for Apple Watch, we have a single lead ECG reading on the waveform. By the way, also, as Dr. Zhao mentioned, this is a new wave of technology collaborating with the medical domain. So joining with multiple different biometric and the physical activities, very likely we are going to identify some supplemental signals, which will be very beneficial to doctor. But the bottleneck is that we cannot rely on doctor to manually process this information, right? Because they are already super busy. It'll be great, for some experts from the software and AI perspective to collaborate with this domain. So this will be in the new innovation, the next wave, right?
Right.
So
for example, we currently use a 14-day monitoring. There must be better devices out there, but we're really not buying their technology. We're buying their service, right? Because they monitor the patient, they come with a pre-made, pre-populated report, and we can just glance through it and click through it. We don't really buy their technology, we're buying their service. So you have to make a distinction between service and technology. If your technology is great, it generates a boatload of data, and that's, no one's gonna buy you. Okay?
Exactly.
Yeah,
exactly.
Service is more important than, as important as technology, okay?
That's right.
Yeah.
So the technology here, Dr. Zhao mentioned, is the data generation, the data collection. That's raw data, volume of data, right?
Right.
Whereas the service here is intellectual, actionable insights analyzed on top of it.
You have to enhance the data quality. You can't be dumping all the raw data on the medical field. No one is going to take it. The uptake will be like, you're going to have a backfire.
Exactly. So that's exactly the aim, the goal we are trying to achieve for this cohort.
The quality of the data. Yeah.
Very nice. Thank you.
Thank you very much.
Yeah, good question. Thank you for the answer. Let's move on to team 5.
Hello, doctor. I'm Faraz, and it's good that 2 out of 4 of my questions are already answered by your previous replies. So I'll go ahead with one of my first question, which I prepared. Like, what is the current process of diagnosing any type of cardiovascular disease in patients who do not have any symptoms yet?
That's a great question. So in general, if you don't have any symptoms, you don't get tested, okay? Unless there's some exceptions, right? So one exception is you have an overwhelming family history, right? Like 3 generations of the males in your family died before age 30. Guess what? When you're 25, you better get checked out. Okay. So that's number one reason. So in general, don't ask, don't tell. If you don't have any symptoms, no one would actually go and give you executive physical, right? But that's still being done. You know, if you're paying like a concierge service, paying like $5,000 per year annual membership, they may do a head to toe on you. But is that necessarily a good thing? I think preventatively maybe, but you know, it's a double-edged sword, right? They may find things which we call incidentaloma, which means, you know, you do a whole body head to toe scan, you find little dizzles here and dizzles there, you don't know what to do with it. It just leads to a string of other testing, which may be more to your detriments than to your benefits. So in general, if you don't have any symptoms, no test is recommended unless there's a compelling reason from a family history perspective, genetic standpoint. Or, you know, for example, if you know, you have a kidney stone, you get a CT scan of your stomach, and by chance they catch that, oh, something's going on with the bottom of your lungs as well, let's go chase it up, right? So those scenarios do exist, but in general, in the field of medicine, I mean, we don't have, you also have to think about the cost effectiveness of doing testing, right? If you do those testing on an asymptomatic population with a very low prevalence of disease, not only is it costly to conduct those tests, but it's also, you have to deal with the false positives, the the false negatives, right? So no test is perfect. Not only tests are costly, false positive tests are even more costly, okay, psychologically and economically.
Okay. So I have one follow-up question. Like, while diagnosing a cardiovascular disease, what is the manpower or time required to do that from a doctor's perspective? I know there's a shortage of manpower. I mean,
yeah, no, I know. I think there's a national shortage of physicians because there are lots of burnout, and you know, people got really burned out, and through the pandemic, and the labor force is suffering through a great shortage, and physicians, a very demoralizing time to be a doctor at the time, because you go through 3 years of extreme work conditions and short staffing, and deal with, you know, really high risk work environment. So it's a lot of attrition to the workforce. So unfortunately, it is still a very labor intensive field. Automation has done some change to some of the field. But I have to say, maybe to our benefit or to our detriment, that a lot of things we do are very hard to replace with automation. So, I think for example, easy thing, electrocardiogram, right? To see if you're having a heart attack, you're having irregular heartbeats, right? So automation is helping. So, you know, all the results come in already pre-populated by the computer, but, you know, I think 20-30% of the time we still have to do manual correction. So a lot of what we do are still very much labor intense and refractory to attempts of automation. Okay.
Okay. Thank you.
Yeah.
Thank you. All right. With that, we can conclude the first round of the questions. We're going to move on to the second round. Now coming back to team one.
Yeah. So, doctor, basically, like we just spoke about the effects of COVID on heart health. Do you feel that vaccines also have a role in it? Like, does a person who's getting vaccinated is susceptible to heart diseases in some way or the other? Does vaccine play any role?
Yeah, that's a great question. Great question. Again, it all boils down to, there's a vaccine adverse reaction reporting system from the CDC, FDA. It has a nice acronym to it. So overwhelmingly, there's nothing that's 100% all benefit and 100% all harm, right? So anything you take, you have to do a cost benefit risk harm analysis, right? So I think one of the references I sent you actually give you a nice diagram in terms of, actually, if I can share my screen with you, I can show you the diagram. I have it right here on my desktop. Let's see if I can share my screen just for the moment. And can you all see this diagram?
Yeah, we are able to see.
Yeah, so you can see, so this is essentially a take-home point for the benefit and harm of receiving a COVID-19 mRNA vaccine after 2 doses in this particularly high-risk group of male, essentially 1 million male individuals 12 to 29 years of age, right? So the likelihood of getting myocarditis, you know, by getting the vaccine, there's 39 to 47 more cases of myocarditis. That's a risk. But in the meanwhile, you prevent this number of hospitalizations, this numbers of admissions, and even this number, 6 number of deaths. So clearly, the benefits outweigh the risk. I think the balance is really tipping towards more beneficial for the vaccine. So there's nothing. I think the diagram should be the other way. The benefits is better than the risks, but it tipped the wrong way. But I think the point is, I mean, for the mRNA vaccines, the most feared and talked about adverse reaction is myocarditis, particularly in the young male age group. And then, you know, I think here there's 6 fewer deaths with a full vaccination with mRNA. Myocarditis, by the way, is also a spectrum. Once you have inflammation around the heart, it's not always fatal, right? So vast majority of myocarditis, even if you get it, is still mild to moderate. The most extreme of myocarditis cases, still even that is even more rare. So I think yeah, I mean, this is probably not enough to convince people who are diehard no vaxxers. You know, they're not going to take any vaccine no matter what you say. But I think there's more and more data supporting the use of mRNA vaccine at this point. But now that with a less virulent COVID strain, you know, maybe the balance is tipped the other way, right? So we all know that the Omicron variants are less likely to cause ICU admissions, less likely to cause even death. I mean, almost unheard of for like Omicron, unless you have really severe background diseases. So maybe that also shifts the balance around, right? So maybe in those cases, you know, you may think, you know, if the disease is so mild, why do I give myself a vaccine? The disease itself is probably the same as the vaccine. So is a moving target, is constantly shifting, is a moving target. I recommend that, you know, you keep an open mind and respect those who decide not to get vaccine. Okay, so those people are not crazy. And plus, particularly when we don't know the long-term consequences of mRNA vaccine, maybe 20, 30 years from now, the no vaxxers are proven to be right. So have a healthy dose of suspicion of new technology and have a respect for people with alternative views. Okay.
Thank you. This brings up a really good perspective. Okay, just like in our software domain, you know, any new technology advancement, you know, recommendation, we need to do due diligence and put another thought. It's always a balance.
Yeah.
Good. Let's move on to team 3, second round, team 3.
Yep. Hey, doctor. So some people in maybe the first or later waves might have experienced somewhat severe symptoms, and post that they have reported like shortness of breath and difficulty to do physical activity. So can I understand like what is the relation with this shortness of breath and any heart related thing, like if you can, yeah.
You mean post-COVID?
Yes.
Okay, yeah, there's a condition. I think if you, the same article I share with you, there's a post-COVID disease, right? So I personally have seen, you know, maybe half a dozen young people usually coming to my clinic complaining of persistent, you know, irregular heartbeats, you know, feeling rushed, feeling fatigued, tired, and just feeling not themselves even a few months, even a year after COVID. So you do a testing, everything comes as normal, right? There's no structural objective evidence of any harm. It's just like a subjective feeling of not normal, right? So obviously we don't know COVID. You know, what is the long-term sequelae of having COVID? Hopefully nothing. It's just like a, you know, run-of-the-mill, you know, is a coronavirus, right? You know, you on a good year, you got coronavirus. There's hundreds of different variants of coronavirus. hopefully this COVID eventually will evolve into just one of the run-of-the-mill seasonal flu, seasonal cold viruses, right? So we don't know the long-term consequences from COVID, and those symptoms usually mild and subjective. So what I tell my patients is, the best medicine is time. Give it a time, and there's no objective evidence. There's heart function is normal. There's no arrhythmias, and there's hopefully eventually your body get rid of it. Is maybe some lingering effects from the immune response, not necessarily from the virus, right? So we know people die not from the virus, usually from a body's over exuberant immunological counter response to the virus that really got into trouble. That's why we use steroids to quell down your body's own immune reaction. So your body immune reaction is going haywire. So maybe it's your body's immune reaction needs time to cool down. So it may not actually be from the virus, maybe from your own body, right? So only the thing I tell my patients is give it tincture time. Hopefully time, like a year from now, if you're still feeling the same way, come back to talk to me. No one has come back yet.
Okay, got it. That's good to know. But just to understand, we are not able to draw any clear relation between shortness of breath and heart conditions, or
And what, sorry?
heart conditions like irregular beat or at myocarditis or fibrillation. I'm not sure of all the terms here.
You're
But
still talking about post-COVID, right?
yes.
Yeah.
So that
okay.
shortness of breath, are we able to
Mhm.
draw any relation to irregular heartbeat or any other heart condition? Or
Yeah, shorter breath, can be from not just COVID, can be from the lungs, from the heart, from deconditioning, from a lot of other different. So a shorter breath is big waste basket diagnosis. Many things can make you shorter breath. So yeah, so that's something we essentially battle with every day. Like, I'm short of breath. Like, why am I short of breath? Can you figure out for me? So that's we spend like pull our hair out trying to figure out every day, why is a particular patient short of breath? Right? Is it from the heart? Is it from the lungs? Is it from the blood? Is it from the endocrine system? Is it from deconditioning? So there are 20 different reasons why a particular person will be short of breath, and COVID, post-COVID is no different, right?
just last question, and then this will be my last question. So how about physical activity post-COVID?
Yeah.
Has that also been related to this irregular heartbeat that you've seen from some of the patients?
Right. So there is a return to activity recommendation post-COVID, only for those people with documented myocarditis, right? So which means your heart function has taken a hit during because of COVID. So if you have COVID infection and you have symptomatic, limitations, but there's no, the heart function is normal, the lung actually looks normal, you just feel short of breath. So, I think there's no hard recommendation of saying, oh, you need to stay home for like 2 months. And the recommendation, go back to school, go back to regular activity, is essentially you're your own boss. Take charge, just don't push your body. If your body says you're not ready, then don't do it. If your body says go take, walk 2 miles, and then you're fine. If your body says now you're ready to walk 4 miles, and walk 4 miles. So the only recommendation that needs doctor's approval to go back, return to normal activity, is for those who actually have documented a decrement in their heart function.
Okay, good. Thank you so much.
Long COVID symptom has been really, popular. I just heard from Wall Street Journal like a couple of days ago in the morning, is 1 out of 5 COVID patients, they have the long-lasting symptoms.
Mm-hmm.
So like the Dr. Zhao just mentioned, in the clinic domain, she must have seen lots of patients coming on a daily basis.
Yeah.
All right. Let's move on to team 4.
Yes. Hi, doctor. So many patients get routine blood tests done on a daily basis. So how often a patient is transferred to cardiac treatment or assessment just with a routine blood test report?
I mean, that's usually they get blood tests done for a reason, right? And vast majority are still normal. They don't need any further action. So in terms of cardiac specific testing, there's a higher chance of patient needs things to be done if they come to emergency room versus they just doing outpatient workup, right? So the specific to the heart, the thing that we worry the most, number one, is what we call cardiac troponin, cardiac enzymes, indicative of cardiac injury, either from inflammation or most often from a heart attack. So if those numbers are up, usually patient needs to be sent to the hospital. And there are other biomarkers indicating heart failure. That's something that we can also react on. The other things, we may send the patient to the hospital, to emergency. For example, if there's a big decrement in their kidney function, that could be from too much fluids in their body, and also be from too little fluids in their body, right? If you're dehydrated, you have kidney failure. If you have too much water from heart failure, then you also go into the kidney failure. So those are the things that we also actionable. And also if you have electrolytes that really is kind of wacky, like particularly potassium, can send your cardiac rhythm into a tailspin. So those are usually the actionable items. Just to summarize, the cardiac enzyme, cardiac biomarkers, cardiac troponin, indicative of myocardial injury, and also a BNP, that's a marker for heart failure, as well as in general, just, kidney function, because the heart and kidney, they're interconnected, and electrolytes imbalance.
Fabulous. Thank you so much. Thank you. Let's move on to team 5.
Hi again, and this will be my last question. So it's like, are there any incidences of misdiagnosis when it comes to detecting heart disease earlier? And if yes, then what are those particular heart diseases or cardiovascular diseases?
Yeah, like I said, any test, right? If you've done epidemiology or biostat courses, any test you do, and cardiac tests are no exception. They have test performances, right? Sensitivity, specificity, that's specific to the test. They could be 90%, 90%, sensitivity, 90% specificity. But if you apply the test to a low prevalence, disease prevalence population, then the test results, the predictive ratio of the test may still be very low, just because you're applying the test to a low probability population. So any inaccuracy will be essentially exaggerated, and in the low prevalence disease population. So we're bound to have false positives and false negatives, right? False positive test, you deal with the subsequent testing, and false negative test, obviously the patient has a disease, but you miss it for some reason, and the disease may progress undetected and unchecked and managed, and that certainly will lead to patient adverse outcomes, right? So, but if false positive and false negative, if you have false positive test, it leads to a string of follow-up testing, right? So that's also costly, not only to the healthcare system, but also to the patient's psychological well-being. So if you're told you have a disease, and God knows how much anxiety and unease that's going to cause a person. Okay.
Yeah.
Very good.
So to bear in mind that even a perfect test, 99% sensitivity, 99% specificity, if you apply this perfect test, near perfect test, to a low disease prevalence population, then the predictive ratio of the test results is still going to show a big decrement. So the test itself and the population you apply the test, both will determine the results of the test.
Okay, thank you.
Thank you. By the way, for this, the testing, specificity, sensitivity, it's all boiled down to the false positive, false negative, true positive, true negative, the confusion matrix. It's slightly different from what we generally use in the software, like precision recall, but with the fundamental matrix, we're able to derive this. Okay, we'll talk more in our course specifically on that. All right. I think we are about to close today's interview. It's some minutes later, after our scheduled time. Is there any burning question you want to ask before we close today's interview session? Anyone? Well, I hope all of your essential questions are being addressed by our Dr. Zhao. Okay, so with that solid understanding in this domain, okay, and the interrelationship between the heart failure, heart disease with some other diseases like COVID, okay, it will set up a good foundation for us to proceed with our semester project. I think one important thing we got to keep in mind is the AI, the cutting edge software technology definitely need to marry with the medical domain knowledge. So the interdisciplinary field is the direction to explore. All right. Thank you so much, Dr. Zhao. Let's give another round of applause to
Oh,
Dr.
it's my pleasure. It's my pleasure to share with, yeah. So, I mean, the cross-pollination between the two fields are definitely necessary because we're kind of like isolating our own little silos, and you're in your own silos. And I think crosstalk needs to happen more often. Okay.
Very nice. Thank you. Looking forward to further collaboration.
Of course. Okay. All right.
Thank you, Dr. Zhao.
Good night, everyone.
Thank you,
Bye-bye.
everyone.
Yeah.
Thank you very
so
much.
much. Bye-bye.
Thank you. Bye.
Bye-bye.